So in this video, I'll be talking about carrier screening for couples planning pregnancy. So coming to the definition, what is carrier screening? So in simple words, it's an attempt to answer the question, are you silently carrying a gene that could cause disease in your future child? So carrier screening is a genetic test done in healthy people to check whether they carry a faulty gene for a recessive or X-linked genetic disorder. A carrier has one normal copy and one faulty copy of a gene. One faulty copy usually causes no disease. Two bad copies in a child can cause serious disease. That scenario will occur if both the parents are carriers for a same gene. Why carriers matter even when they are normal? That is because most severe childhood genetic diseases do not come from sick parents. They come from two perfectly normal carriers. So, do we need to screen for all the possible genetic disorders? No, simple. That's because there are certain genetic disorders which don't cause early lethality, severe functional disorders. There are disorders which won't affect the activities of daily living. So, such disorders are usually classified as mild disorders. So, mild disorders, it's not important to screen. We have to screen for severe, profound, or at least moderately severe disorders. So, classify on what basis we classify as profound, severe, or moderate. So, there are certain clinical features which are characterized into certain tiers. So, tier 1 include the disorders which cause infant or childhood mortality or intellectual disability. Tier 2 are those clinical features that include premature adult death, impaired mobility, major internal malformations. Tier 3 sensory impairment, immunodeficiency, mental illness, dysmorphic features. And tier 4 is reduced fertility. Obviously, in a population perspective, a disorder causing reduced fertility is not a concern because that person can still have a quality life, that person still can have a good impact on the society, and he can live independently. So the first three tiers of clinical manifestations are important for us. So based on these tiers of clinical manifestation, we have classified the diseases into four categories. Those are profound, severe, moderate, and mild. So if we have to classify one disorder as profound, there has to be more than one tier 1 characteristic. If we have to classify a disorder as severe, there should be one tier 1 feature or tier 2 with additional burdens, and moderate tier 2 or tier 3 features without tier 1. I haven't specifically mentioned mild diseases. So mild diseases are not important when it comes to carrier screening. So I have given examples also on the right hand side of the slide. Previously, carrier screening was all about what was prevalent in that population. For example, we know that in among Jews there are certain disorders which are very common. So we used to classify people based on their ethnicities, and there were population databases based on which we used to decide what diseases to be screened for a particular ethnicity. Then later on we realized the flaws in that. The carrier screening was started as early as in the 1960s. At that time, it was mainly targeted specific groups like Tay-Sachs disease in Ashkenazi Jews, sickle cell disease in African individuals. The flaw was that later we realized that the self-described ethnicity has inherent and unpredictable inaccuracies. And genetic ancestry often does not align with the self identification. If a person identifies him as, for example, a Latino, there are possibilities that one of his father was not a Latino. He might be a, say, for example, an East Asian. So there will be always be a mixture of genetic content. So a population based universal carrier screening program has to be population neutral, because as such the self-identification of ethnicities will cause missing of certain diseases which need to be actually screened. So the consequence of self-identification of ancestry was that an ethnicity-based approach creates inequities in care, providing an incomplete information for reproductive decision making and missing at-risk couple in the general population. So the current approach is an ethnicity-neutral approach and universal approach. So the new standard is universal tier 3 screening for all. This is not the tier 3 which I talked few slides before to classify the diseases. So ACMG classifies the newborn into 4 tiers. So the current recommendation is we have to offer tier 3 investigation to all the couples. And this detail, this new approach is ethnic and population neutral to promote equity and inclusion. It replaces the vague term expanded carrier sequencing with a precise tier-based system. And the goal is to provide a consistent, equitable, and evidence-based approach for all individuals. So these are the tiers. Tier 1 means cystic fibrosis plus spinal muscular atrophy and risk-based screening. Risk-based means, for example, if there is a genetic disorder running in the family, we have to screen for that also. Look at that. We are practically screening for a very small amount of genetic disorders. Obviously, this is not enough. So tier 2, we have included all diseases in which the carrier frequency is more than 1 in 100. So if the carrier frequency in a particular ethnicity for a particular disorder, if it is more than 1 in 100, then that disorder needs to be screened, provided it is minimum of the severity moderate. Moderate, severe, and profound diseases are screened. Tier 3 is the latest recommendation. So tier 3 means all the diseases in a population where the carrier frequency is more than 1 in 200 are screened and includes X-linked conditions also. So I will explain what is carrier frequency and is it population dependent. Obviously carrier frequencies are population dependent. So if we then, it creates another confusion. If we are choosing diseases based on the carrier frequency of a particular population, we are indirectly going into ethnicity based screening. So our approach is ethnicity neutral screening. So how do we address that? So all the diseases which have at least 1 in 200 carrier frequency in any of the ethnicities, for example, an ethnicity which has a significant population across the world, if that ethnicity has a carrier frequency of more than 1 in 200, obviously that will be included. For example, in Hispanics, the carrier frequency of cystic fibrosis, for example, I'm not taking the actual values, is 1 in 250, for example. However, in the Afro-Americans, the carrier frequency of cystic fibrosis is 1 in 100. So even though the Hispanics, they have a lower frequency than 1 in 200, because one of the major population has it, like Afro-Americans, the universal screening panel of investigations of Hispanics will also include cystic fibrosis. Why is it so? Because we have already explained that ethnicities don't go by self-description or self-identification. There will also always be myths and matches, and there is a possibility that one apparently Hispanic will marry an Afro-American, some Indian will South Asian will marry an East Asian. So always there will be a mixture of genomic material. And also we have included selected number of X-linked condition. So we know that all these carrier frequency applies for autosomal recessive disorders. X-linked conditions are different. Only the female transmit the disease. So selected X-linked conditions should also be included. So at the when we include X-linked conditions, we cannot go by the rule of carrier frequency. So I will tell you how the X-linked conditions were chosen in the subsequent slides. Tier 4 is diseases which have even less than 1 in 200 carrier frequency. So you may say that that's the best approach, right? So what's the problem? We may even choose some ultra rare diseases in which we don't even know the clinical and untreated clinical course, what will be the severity. So there will be only some few case reports of a particular disorder. So we don't know the clinical course, we don't know the penetrance, we don't know the expressivity, then how can we include that disease in the carrier frequency? So that's a problem. So tier 4 is not clinically indicated. However, there is one special condition in which tier 4 is indicated. That is because that can be done if the couples are consanguineous. So we know that if there is a consanguineous marriage, even ultra rare diseases can manifest in the children because there is a higher chance because the genetic material are same. So tier 4 is done when the couple are consanguineous. Otherwise, for an if there is no consanguinity, and as a routine practice, we have to give option for tier 3. So if a person comes and a medical rep comes to you and says, "Sir, we are offering say 200 diseases panel for genetic screening," that may not be a tier 3 because we have a set of diseases. Only those diseases have to be there. So even if they are providing 50 extra diseases screening, however, the tier 3 panel is incomplete in their panel, then definitely that is not tier 3. So tier 3 ACMG has clearly defined the diseases that are coming in tier 3. If you go to ACMG website and download the article on carrier screening, they have provided supplementary material. So they have clearly mentioned all those autosomal recessive and X-linked conditions which comes under tier 3. So the tier 3 panel includes 97 autosomal recessive genes and with carrier frequency of more than 1 in 200 in any ethnic group with reasonable representation in United States. So even though ACMG defined it based on ethnic groups in United States, because the frequency is not as high as 1 in 100, it's kind of liberal cutoff of 1 in 200. This applies to almost all populations across the world. So even though it was defined for United States, logically it will apply to all the populations as well. And disease severity has to be at least moderate. And the carrier frequency was derived from certain databases like Nomad and supplemented by clinical expert review. And all those popular diseases, sickle cell anemia, beta thalassemia, cystic fibrosis, Tay-Sachs, phenylketonuria, Wilson, all those diseases are included. And coming to the tier 3 panel of X-linked conditions, the panel includes 16 X-linked genes. So how was those 16 chosen? The disease prevalence has to be 1 in 40,000 at least. So this 1 in 40,000 was kept arbitrarily, and obviously the disease severity has to be minimum moderate. So we cannot go by the carrier frequency here because X-linked works differently. Only female transmit the disease. So we have kept a prevalence for the disease as a cutoff. The famous one include Fragile X syndrome, Duchenne or Becker muscular dystrophy, hemophilia A and B, Fabry's disease, OTC deficiency, which is a urea cycle disorder, and X-linked adrenoleukodystrophy. There are around 16 X-linked genes. So what all we need to do in pre-test counseling? Always remember, screening is optional. We can give option, but this is not a mandatory test. They can opt out also. Pre-conceptual screening is ideal because that's the best time to screen, and we can decide on the how we need to tackle if a variant is identified. And a negative result reduces risk but does not eliminate it. Always remember, there are certain genetic variants can be missed in the screening. I will explain in later what are the possibilities of a false negative result, and explain the potential results that you can be a carrier, your husband can be a carrier, there can be an X-linked condition coming out, and the possibility of variant of uncertain significance, that is VUS. VUS are usually not reported in couple carrier screening, but it can be reported if there is if one of the partner is a carrier for a likely pathogenic variant. For example, the male partner has a cystic fibrosis pathogenic variant, and the female partner does not have a likely pathogenic or pathogenic variant of cystic fibrosis. However, she harbors a VUS, then it needs to be reported because the VUS, we all know, because the classification can change with time, and we need to be careful. And if needed, we need to establish its importance. If we have to do literature search, we have to go by databases, in silico prediction tools, and find out whether this VUS can cause disease. And information that tier 3 screening should be offered even if tier 1 or tier 2 was performed in prior pregnancy and it came out to be normal. We always have to go by tier 3 screening. And there will be possible two scenarios. One is one partner is an identified carrier. Then we can do a sequential screening. Then we can screen the second partner. Then we can provide education and recommend a follow-up screening of the reproductive partner. And crucially, the partner testing should include full gene sequencing, not just a limited variant panel, which was identified in the first partner. The second scenario is an at-risk couple is identified. What is an at-risk couple? A couple who both of them are harboring a pathogenic variant or likely pathogenic variant in same gene. So there is a 25% risk of recurrence. Or a female who is harboring an X-linked recessive disorders gene, and there is a chance of having affected male child. So then we have to explain the possibilities of this test like IVF with uh, pre-implantation genetic test, donor gametes, adoption, prenatal diagnosis, etc. Then during pregnancy, we have to offer chorionic villus sampling or amniocentesis and discuss options regarding testing. What are the challenges in implementation of this tier 3 based genetic screening for carriers? Some variants lie in deep intronic regions. So we know that we usually go by next generation sequencing. And there are certain tests like MLPA which need to be done. I will explain that in the further slides. So if we are going by NGS, certain variants which can cause damage will be lying in the intronic region. So in whole exome sequencing, we see we sequence only the exons. So all exonic variants which contribute to around 90% of the total damaging variants can be picked. However, 10 to 15% cases will be missed, which are due to intronic regions. And some regulatory region variants can also be missed. And even if the technique is robust to detect a variant, the detection rate may not be 100% for all the assays. And not all disease causing genes are known. Genetics is evolving. We are discovering more causative genes for diseases, and our knowledge at this point of time may be limited. And de novo mutations can also always happen. De novo means parents are not carriers, however, the child developed a mutation. That is called de novo mutation. That is always possible. And dominant diseases behave differently. This genetic carrier screening is basically for X-linked recessive disorders and autosomal recessive disorders. Autosomal dominant disorders are always, most of the time, are de novo. Sometimes it can be inherited. However, because autosomal dominant diseases classically show a pattern called incomplete penetrance and variable expressivity, the parents may not show any symptoms. So in that case, we may miss that in the screening. Then coming to what all tests to be done. So there is a whole set of tests that need to be done for the couple. NGS based carrier panel, it will detect almost more than 100 genes, and we need to do for both partners. Spinal muscular atrophy need to be done by MLPA or an equivalent. Both partners testing need to be done. Alpha thalassemia deletion testing need to be done because these SMA deletion, alpha thalassemia deletion, and triplet repeat disorders expansion cannot be detected by whole exome sequencing, that is next generation sequencing. So special tests need to be done. And Friedreich ataxia due to GAA repeat expansion need to be done using TPPCR in both partners. TPPCR means triplet primed PCR. DMD exon deletion duplication analysis should be done by MLPA or a validated CNV assay. And because it's X-linked, only female partners test is enough. And for Fragile X syndrome, CGG repeat analysis need to be done by TPPCR, triplet primed PCR. Again, since it's an X-linked disorder, we have to test only the female part. So this is, you can see the problem also. An extensive panel needs to be done to satisfy tier 3 screening, and each test is costly. Even though the cost of genetic test have nosedived, still it's costly. An NGS in India will cost around 9,000 to 10,000 rupees. If we are doing for both, it will cost some 18,000 to 20,000 rupees. SMA MLPA for both partners will cost around 6,000 to 8,000 rupees. So if we calculate, it will cost some, say, more than 40,000 for both partners included. All the people in India cannot afford that. Then what can we do in India? So this is a practical solution. So IAMG, Indian Academy of Medical Genetics, have considered this, and universal screening of thalassemia and SMA are the tests recommended in India. So thalassemia can be easily screened with hemoglobin HPLC. So in hemoglobin HPLC, both parents are having hemoglobin A2, HbA2 more than 3.5, then the second tier testing can be done using an HBB sequencing. The advantage of thalassemia detection by HPLC is that HPLC is relatively cheap. So we, if one of the parent is having a HbA2 of less than 3.5, we can comfortably rule out the possibility of thalassemia. SMS screening needs to be done with an MLPA based testing. And expanded carrier sequencing by NGS is recommended if it is a consanguineous couple, family history of a monogenic disease, or a possible monogenic disease. For example, their previous two children died due to some cystic kidney disease. Then the possibility of monogenic causes are high. Then bad obstetric history due to possible monogenic causes. For example, two of their children died due to some some unknown disorder which was labeled as sepsis, which can be an inborn loss of metabolism and in the first week. So that's a bad obstetric history. Recurrent IUDs, recurrent intrauterine deaths, stillbirths, all these are likely due to monogenic causes. And then we have to offer for expanded carrier sequencing. And a practical solution. This is not a guideline. This is purely a personal opinion. This is what my seniors and my faculties and I usually practice. So if a patient comes to us, the usual conditions that we screen for is thalassemia using an HPLC, SMA using an MLPA for both partners, and DMD, MLPA of mother, that is the female partner. These three are the usual investigation that we offer. And expanded carrier screening by NGS if first fetus or child is affected due to a possible monogenic cause. For example, sometimes they will come with a history that previous child had some kind of, say, aplastic anemia. Then we have to always suspect something like a Fanconi anemia, like that. Suppose if the affected first child is alive, always it is preferred to test the child first. That's the best possible intervention. If the first child is dead or his or her sample is not available, then we have to go for expanded carrier sequencing by NGS of couple. And always consider karyotype for recurrent pregnancy loss and a bad obstetric history if we are suspecting a chromosomal deletion or duplication. For example, uh, uh, a patient coming with history of two recurrent pregnancy losses and a third child with multiple malformations who died early. In that case, we can suspect that there can be a balanced translocation one of the parent who which might be the cause of this particular uh, scenario. So karyotype is not included in carrier screening. However, we have to give an option if the history is suggestive and if there is an indication. This is a practical solution because in India, the money is a limitation. So thank you.